Hi, everyone. Thanks for joining us for another episode of Overfilled, the podcast, where the Opto besties get together and talk about all things that are overfilling to us about our practice with specialty contact lenses. I am Dr. Brooke Messer, and I'm here with my bestie, Dr. Jamie Kuzner, and our mentor and I was going to say third wheel. That's not right. And the third person in the trio, I'll just call it that. Dr. Jason Jedlicka is out today, so it's just the two of us hanging out, and we're going to talk a little bit about deciphering vision complaints in patients who wear basically all, custom contact lenses, but primarily sclerals. We're going to talk a little bit about that today. But first off, let's go over what has overfilled us since our last episode. And Jamie, you going to kick us off?
Sure. So I had the great honor a couple days ago where the MOA awarded me Young Optometrist of the Year for Michigan. And yes, I know you're thinking, is Jamie really even that young? But it turns out I am.
Yes, you are.
So to be young OD, you have to be 10 years out or less. And this is actually this is year 10 as of this month for me. So I know it seems like I've been around forever for those of you that listen to me lecture. But so yes, that was such an honor. And it was great because my one of my really good best friends that nominated me got to give a wonderful speech and award it to me. And it was great. So it was a really fun time. I got to get some CE earlier in the evening, but so very happy to get young OD. And Brooke, you got OD of the year, right?
Yeah, I got old OD of the year.
Old person.
We are currently just kicking butt, taking names.
That's so funny. So yeah, Brooke was OD of the year, and then I'm young.
So good. Yeah.
So there you go. But that was my overfilled. So I was really grateful to receive it.
Yeah. Got a comment on, I like the brunette hues that are coming through up there, or the dark blonde, looking nice.
Thank you. That actually was because I had to reschedule my hair appointment, and she was booked out 10 weeks. So
well, I think it looks nice.
What started as an ombre has turned into like a really big ombre.
It kind of does look a little balayage, though. I mean, I like it.
Yes.
I like it. Looks good.
Yes.
And the curls look good, too. We don't always see that from you.
Thank you. I appreciate it.
On my end of things, just end of year fun. Hunter had his kindergarten graduation. That's him there in the middle. That was yesterday afternoon, so that was fun. And I decided to include a picture of Brian. I don't talk about him a lot on the podcast, but obviously you probably feel the same, that we can't do what we do and travel like we do without someone solid at home. So I had to give a little shout out to Brian today too, on just, thanking him for all the support that he provides to the family while I'm off chasing big dreams. And of course, a 6-year-old boy would provide a face such as that.
Oh my gosh.
And then lastly, of course, have to balance it out. Got to include Nora too. Nora won principal for a day at a school raffle. And so that was her day where she got to walk around with the principal. She got a walkie-talkie, a little badge, and she got to meet with students in the office. And so she had a fun day doing that too. So just all in all, again, like all fun things, end of year. And it's already their last day of school next Wednesday. So we're full ahead in summer planning mode, making sure that, we keep our heads on straight as we enter the summer. So with that, let's go ahead and jump into what we're going to talk about today. And again, we're going to talk about vision complaints in patients wearing scleral lenses. So Jamie, when you think of a patient who comes into the clinic, and you've seen them before, so you saw them last year, everything was going well, and then this time they come in and they say, my vision's not as good as it was last year. Sometimes my vision's good, sometimes my vision's bad. It fluctuates a lot. What do you think about, or how do you work through those patient complaints to kind of decide, where do I go here? Where do I go next with this exam to figure out what's going on?
For sure. I usually start front to back. So front being, look at the front of the lens. So front of the lens, midday fogging, cornea, cataract, like everything all in between, front to back. I actually had both happen this week. One of them was front of the lens and one of them was retina. That's funny, within like 2 days. So especially if they ever come in like mid-year. Mid-year is always like a red flag, especially if they've been stable for so long. Like their eye and their fit shouldn't change drastically in a few
Right.
months, you know? So a lot of it is, okay, how long have you noticed it changing? Does it fluctuate day to day? Does it fluctuate when you blink? Or is it constantly hazy and blurry all the time? So I think a lot of times even just talking and getting a good history you could pretty much probably figure out the problem is before you even look at any imaging or the lenses. So that's kind of like, I have my technician ask all these questions before I even get in the room. So a lot of times you can determine, is it front surface wetting? Does it fluctuate day to day? Does it get worse at the end of the day versus the beginning? And I see you have this like wonderful, image here on our left too. What I
Yeah.
do a lot for my scleral patients is part of like our normal workup is we'll do an OCT. And the nice part about my OCT is it takes a picture of the front of the lens and it takes the OCT of the lens. So I like that I can show the patient when they say my lens is foggy. If it's the front, I can show them the picture of the front being foggy and saying this is like either a you problem or an environment problem. And if it's the inside of the lens, I can actually show them, yeah, it is foggy. There's debris in your reservoir. I think that helps them to understand, what's going on with their lens and their vision, or maybe it's not even the lens at all. So, what do you normally do, Brooke?
Yeah, so I do the same. I try and find out those questions on does it fluctuate or not. And normally, if it's the surface, the vision is clear immediately after the blink for a short period. And then as they hold their eye open, it gets blurrier. So, if, I'll have them look at the visual acuity chart. And if they just like rapidly blink, how's the vision there? Versus if it was a post-lens tear reservoir clouding, then obviously it doesn't matter how much they blink. And it's only relieved by lens removal, refill, and replace. This patient here on the left was actually somebody that I saw yesterday. And she is somebody that struggled with front surface deposits for a couple of years now. And she does have hydropeg on her lens too. So she just burns through it with those deposits. And however, I've never tried the whole tangible system with the boost, the cleaning solution, tangible fill, kind of the whole thing. And I had quite a few samples at the clinic of the tangible boost, actually. So I reordered her lenses with hydropeg and included a boost kit with her. And I also actually did lacquer fill in her puncta as well. She's depositing something because there's a dry spot on her lens. And so we need to maximize that tear film to make sure there's no dry spots. Because when there's something dry, debris sticks to it, and then debris sticks to debris, and then you get these big old clumps. And certainly this was easily removed in office with just Boston Simplus. I just cleaned the surface, took the lens out, cleaned it, put it back in before she left. But it won't take long before they show up again. And so first off, if I do believe it's the front of the lens or, can see it like this, in this case, I'm just doing everything I can, not only to provide opportunities to keep the lens clean, but also boosting the tear layer to make sure that we don't allow for those dry deposits. And the other thing that we can't forget to mention about a scleral lens too is the back of the lens. Sometimes you can actually see film build up on the back of the lens. That looks more like a biofilm versus distinct deposits like you can see on this image. And that's going to be your men with large, thick fingers, if you would, where they just physically cannot get that pinky finger down into the kind of the depth of the bowl of the lens, or women with long nails. And so that's when I would actually, advise them to use, I go back and forth on like, is a Q-tip okay? Or will it scratch?
Like, is it going to scratch it?
Should they use like just a dampened like glasses cloth? Or, and how do they keep that kind of cleanish? Does it get gross? So I do struggle a little bit on like what to tell them to do there, but I usually tell them to use like a lint-free cloth and, try and get in there if they do have nails, to make sure that they get into the back surface of the lens. Primarily, you see this on those more advanced cones where their lens is really cupped and it's just hard to get into the depth of it. So do make sure that you're looking at that as well. That helps. It's almost, this parallel pipe beam that you see on this one is really for evaluating the sagittal depth of the lens, but I was trying to illuminate the deposits on this image with that one. But if you go a little bit wider on your parallel pipe, focus on the backside of the lens, that'll show up really easily. So don't forget about the backside of the lens too.
I feel like a lot of times it's the front side, and it's funny because patients they assume it's the inside of the lens, and they like are really good at trying to clean the inside. And then when I asked them, I'm like, "Would you, before you put it in your case, like, are you rubbing the front of your lens?" And they're like, "No, because that part doesn't touch my eye," or like, I don't know, like they don't think that they need to clean the front. And so if you can take a picture, I think that really helps them to click. You know, the patient I had this week in particular, he was a young guy, and he said like the last couple weeks, only his right eye, had been really foggy. And so then you have to think, okay, does he have an infection? Does he have something going on? Like, why would it just be one eye, 10 months into his fit? And he came in, and he works in auto, and he just had this like non-wetting spot on his lens. And so I'm like, something physically got on your lens. And he's like, I've tried to clean it. I did clear cure, whatever. So I used a more like abrasive cleaner in office and polished it up. And it was better. But I've had that happen with people that work in like hairstylists that use a lot of hairspray in their environment over and over and over. Sometimes it just kind of starts to gum up the lens, and they might need a more abrasive cleaner because of the environment that they work in.
Yeah.
In
You
April,
kind of Progent for that.
yes,
Progent
yes.
is the best. We have just cabinets full of Progent. I feel like I offer it every visit to every patient.
Yeah, especially like in April for us, that's when our peak allergies are in Michigan, anyways. And I will pretty much tell them every year to do Progent. And then they'll come in almost every year having the same complaint midway through the year. And I'm like, so you remember when we talked about like how the environment and allergies are like, oh yeah, but a lot of times they assume it's the fit, and I need you to fix the fit. It's the fix. So sometimes it's treating the allergies. Sometimes it's just making sure that they're cleaning their lenses, especially when they've been wearing them for many years. I feel like they start to get a little lazy and skip steps.
Yeah.
So they just, it's been a while since they've done their class of like how to truly take care of their lenses for like 5 or 6 years. So it's just kind of reminding those things too.
Yeah. How about the post-lens tear layer? If a patient comes in, what would they mention to you that would make you think, okay, this is not the lens itself, but maybe a fluorescein pump or a debris pump?
Yeah, usually it'll be after a few hours. And I always ask them, does it get better when you put fresh saline in and put the lens back in? Then it's probably midday fogging. If they say they take the lens out and put the lens back in and it's the same, I'm also wondering about, is the cornea swelling, depending on their condition. So if it stays blurry even with my lens out in my glasses, then I worry about like swelling. But a lot of that we can see easily too with midday fogging, putting fluorescein on the outside of the lens, seeing where the lens, where the fluorescein uptakes in there. If you have OCT, you can physically see how much fogging is in the chamber also,
which is
so
really
that's nice. That is super nice. Because I'll even have times though where patients are like, man, it gets really foggy. And I look at the OCT and that's like crystal clear. And I'm like, are you sure? So what does really foggy mean? But a lot of times it's just using fluorescein and your slit lamp and seeing where the leak is essentially, where they're getting a lot of junk in their lens. So I think that is probably it for most scleral lens fitters, the most common cause of midday fogging, vision getting worse throughout the day. That's probably the trickiest and the thing that we're constantly tweaking throughout the fit.
Yeah, and you can see that image there. This is a patient that presented wearing lens on eye, and I popped some fluorescein on the superior conj and then had them blink a bit. So you can see that. And I think 10 and 2 are kind of those common places that it tends to pump in, and it's sort of in between those major meridians of the eye. So it's trying to line that all up with and sealing those little edges down on kind of those oblique axes, if you would, of the sclera. And so whether it's limbo clearance or edge adjustments, that's what we're looking at there. Certainly, dual sag chambers like bi-elevation can also really help with midday fogging. I think one of the most important things to me on all scleral fits, but definitely when troubleshooting patients who have a history of fogging, is making sure that chamber is centered. And so really looking at the toricity of the limbal area, matching that up, and then also matching the scleral toricity or asymmetry in the shape is really helpful there. And certainly reducing lens movement is another one. And then my last tidbit for that would also be looking at the OCT. I love how OCT is making a comeback, because I think OCT images tell a really great story, and it's not about the edge anymore. We used to use OCT to look at edges. but the conj is so forgiving that a poor fitting edge would be so obvious in the slit lamp that I don't know that the OCT tells the story for the edge. For me, it's about chamber shape and matching that base curve to the shape of the cornea, because then you'll get that nice mid-peripheral alignment too, or symmetry between the lens and the cornea, and that really helps reduce that excessive clearance in the mid-periphery, which will just decrease space for clouding and debris to build up to. My resident, Dr. Nelson, and I had a patient like that yesterday, where we're working with a patient that has just a really, really small but very steep central cone. So we were looking at, comparing the shape of the scleral lens compared to the cornea, because she's struggling with a little bit of lens decentration due to just the weight of that tear reservoir, because it's just so asymmetric to the rest of it. So we're going to pull in that mid-periphery by changing the base curve. So again, the OCT is telling a new story versus what we used to use it for, and matching it up to the cornea, I think, is a great tidbit for kind of all things: lens movement, lens centering, and midday fogging too. So those are great ways to pin down, where the source of the fogging is coming from, and kind of improve all things. Minimizing that excessive clearance in the tear reservoir in that mid-periphery is good for the cornea too. We don't want to have excessive tear layer thickness, which would decrease oxygen to that area of the cornea also. So it's just good for everything.
My other tidbit is, are the lenses in the correct eyes?
Yeah, there you go.
That happens a lot also. I had a patient this week have 2 left lenses in, one on both, like the right one had a left and the left one had a left. And I was like, interesting. That's probably why you're not seeing well. Or last week I had a patient where she was in like a quad, a quad lens. So it has to be put in with the dot at the bottom.
Yeah.
And she's like, man, like some days it's really great. And then other days it's really foggy. And I looked at it and her dot was at the top.
Yep.
And I was like, so remember, like you have to put the dot at the bottom, because otherwise it's not going to align well. And so I like spun it, and I'm like, all right, now wear this for another week in the correct orientation, and then tell me if you're still having fogging. Because if you don't look at some of those things, is the lens an upside down?
Yep.
Well, yeah, like that's why some days it's great and some days it's not. So there's like little things where it's not, you don't have to reinvent the wheel here. Just like look at it, especially if there's, markings on there, ID numbers, letters, make sure they're in the correct eyes. All very silly things, but really easy for patients to mix up.
Yeah. So if we move, from the lens and the tear reservoir to the cornea, I can't say I see this all that often, but when we talk about cornea swelling, most of my KC patients, I can't say that they have visually significant corneal swelling. So most of the time that cornea swelling is eyes that have endothelial compromise. So either they have gutata and we know it, they have a PK, which they don't have to have gutata to have swelling. It's just, we know that the endothelium is compromised, or they just have less volume of endothelial cells in a PK. And maybe like there might be a little bit of, or I shouldn't say there might be, but I would say perhaps patients that have had RK may experience some corneal swelling with lenses on eye over time. But that's, again, like Fuchs and the PK are the 2 big groups. Do you see it in any other patient group where you would like go right to maybe this is a cornea thing versus a lens or tear reservoir thing?
No, it's usually those 2. But mostly it's usually my PKs that I'm like the most worried about too. But especially if they say the lens will be foggy, their eye will be foggy for like days, or the whole rest of the day.
The vision is foggy even with the lens on. Yes.
Yeah, even with the lens on, or if they take it off and go back to their glasses. And sometimes too, if I have a really sketchy looking PK, I will have them dispense the lens in the morning, and I have them come back on the same day. Especially if they're a high risk PK, if they're like they literally have one eye and it's like their 3rd graft and it's a very high risk situation. I'm like, can you just come back at the end of the day?
Yeah.
And I can, 1, you can see what their vision. 2, I like to do before and after pentacams. That way I can get a really good, like, the whole packy instead of just one spot. So that's been really helpful for me too. But yeah, especially a lot of it's just talking to them though. Like you can tell immediately, and they kind of know too what to look for. But like kind of moving past the cornea too, I had a patient this month that had randomly anterior uveitis in the one eye.
Yeah.
And he just said, my eye is kind of sore and it's just not as clear. And so, of course, you think like, all right, maybe the lens is too tight or whatever. And I'm looking, and you look past the chamber and and then you're like, oh, well, you have sullen flare. So now you have uveitis. So sometimes it can be uveitis. But sometimes if you're so hyper focused on the lens, is the lens foggy? And they say, oh, I have pain, I have eye strain, and whatever. You're thinking power. Am I thinking, is the lens too tight? And it's like, oh, you have uveitis. So like go back to optometry 101, like why does someone have like light sensitivity and pain, right?
Yeah.
So it could be uveitis. And then that's not as common. And then of course, like, is it a cataract?
Yeah.
I mean, I pretty much had all these last 2 months. I had a patient that he had PCO, and it's funny because he didn't disclose to me that he was a diabetic. And I'm looking at it, and he's young. He's like 45. And I was like, that's really weird. Like, you have a really interesting cataract in your one eye, and you're pretty young. He has like a bunch of PSC in the one eye. And I was like, how are your blood sugar? He's like, well, I'm borderline. I was like, well, what's borderline? He's like, well, my A1C was like 10. I said, 10 is not borderline. What is going on, man? But of course, it's like they think midway through the year their scleral changed, but they have a cataract or they have PCO, like in your image. And then the one on the right, if you're watching, that was my patient right before we recorded today, that he got cleared by his ophthalmologist that the doc either needs to get you a better fitting scleral because you're only 20/70 and he just has pellucids and his cornea is not scarred, right? So if someone's cornea is not scarred and their lens fits pretty darn good, they should not see 20/70. And so they said, if your doc can't get you a better fitting scleral, then we're just going to have to do a cornea transplant. And I'm like, I'm looking at his cornea, like this is not a 20/70 cornea. And Brooke probably knows what I mean by that. Like you can look at a cornea and know. And I said, can we just run a macular OCT, please? And we ran it, and that was his macular OCT right there. So yeah, so that's definitely not a lens thing, and that's not a cornea thing either. That's a retina thing. So you need to get, I'm not sure what's going on. You need to get like a fluorescein angiography. We need to figure out what the source of what this is and what the swelling is. So whenever something doesn't make sense with the drop in acuity, then I'm running an OCT of like the nerve in the macula. I've seen some issues where at some point they had really bad issues with glaucoma, nerve damage, etc. And I think a lot of times it masquerades as you have keratoconus, your eye is just weak. And it's like, well, there's more things going on than just the lens.
Yeah. And the other thing that, one is just like we've covered today, that first off, front to back, all those things, tear film lens, front and back of the lens, reservoir, cornea, both sides of the cornea. So we can't forget that there's a entire eyeball behind this lens that we are managing. So you got to think about the whole eyeball. And then the other thing too, is the patient needs to remember they have a whole eyeball.
Yes.
One of the things that I run into in my practice, just being, out not in primary care, is that patients will be like, oh, like, when was the last time your eyes were dilated? Have you seen Dr. So-and-so? And they're like, well, I haven't seen them since I came here because I only see you now. And so that's just a reminder too, if you happen to be in a setting where maybe a patient was referred to you, make sure the patient is clear, or between you and the provider. Jamie, you may have patients that are referred to you and then the provider just kind of says like, why don't you just take this patient for all things? Every once in a while, right. Jason and I would get that in the practice, or even, Dr. Zach Holland, when we practiced together. On our referral form, it said like, I would like to continue for the referring provider, check a box, I'd like to continue primary care. You guys take care of the contacts, or, just please take this patient off my hands. Like, I would just like you to manage everything. But in my case, we don't do the primary care. So these patients need to understand that, hey, now you have two eye care providers. You have your scleral lens and your regular eye care provider. And so I was reminded this week that like, oh, patient didn't realize that, I'm not doing the full primary care. So I need to keep that in the forefront too. So just remind your patient that just because you're maybe evaluating their KC doesn't mean that we're always evaluating the whole eye. Again, it's kind of case specific, but that's something that we need to remind the patient too, that just because you have keratoconus doesn't mean the rest of your eye gets to be healthy for the rest of your life.
Yeah, and I have a pretty strong policy too that unless I have a documented recent like dilated exam from wherever you're coming from, we are going to be doing that either today or at your follow-up. Okay. Because a lot of times I get referrals and patients are like, oh yeah, so and so referred me here. I was just there. Like, great. And then we get records and it was like 4 years ago. And they finally got around to coming in. So I always just say, I want to make sure you're totally healthy. Or sometimes even cornea will send to me and I'll get their exam and they just did a corneal exam.
Right.
They actually didn't do a full exam either. And so then nobody's done a full exam on these people in years, because cornea is assuming whoever is doing their primary care, is doing the full, and then, the patient just gets lost in the shuffle. So I always like to get records, and I know it's annoying to have to call and get records when people, you don't work in a hospital setting or something where all the doctors are with you, but it's so important. And I've just seen some really interesting stuff, unfortunately. Like someone's glaucoma gets worse because they assume that like whatever drops they're on for their PK is actually treating their glaucoma. And it's like, no, like that has nothing to do with your glaucoma. You haven't seen your glaucoma specialist in many years. So it's just kind of talking to the patient. I don't love doing a lot of retina and glaucoma stuff, but I still have the testing to do it here in case they need it to be done. And I love having my OCT just to like troubleshoot. I have an optos. I love the optos for looking at the whole retina, especially when there's a lot of distortion centrally. Sometimes it's hard to like image through the cornea. So it's really nice to have a wide field view of everything else going on for my cornea patients. And especially if they're like, oh, I was just dilated like 3 weeks ago. It's somewhere else. And I don't want to get dilated again today. And I'm like, all right, I just need it for my own peace of mind, see what's happening in the retina. We'll just do a quick like wide field. Just to make sure we're not missing anything. So I like having all those tools in my toolbox, and I'm very fortunate that I have those. But a lot of times it's not the lens, right, Brooke?
Yes. Yeah. So,
but especially those nerve and macula too. Usually I can tell when they're reading the VA charts, especially if it's macula. They'll say they can read like the first and last letters, and then there's like a missing chunk in the middle. And I'm like, why do they keep missing all of them? And they're like, hold on, I got to move my head around to kind of like see past it. I'm like, that's not a cornea thing. So that's not a cornea thing. So it's good to, not just think about the lens, remember the whole patient, and think about how they're reading the VA chart and kind of some of these other little tidbits that they're giving you feedback on subjectively as they're talking to you too.
So I think that was a pretty good summary of front to back on the eye. And my main takeaways would be, talking to your patient and reminding them about care systems, at every visit. I think that's a great one. And then also just, again, making sure that the entire eyeball is taken care of for our patients. If you want to get in touch with us, we are on Instagram, Overfilled the podcast Overfilled _ the podcast. On Instagram, we're on Facebook. And Jason usually manages the banners. And so since he's not here today, I'm going to mess with that. I'm probably going to end the recording. So just find us on Instagram. And looking forward to seeing you all next week. Actually, next week is Memorial Day. Jamie's got some exciting travels to Spain. Hey. I am traveling to Bismarck, North Dakota. Woo. So we'll catch you the week after that. And we're working on another special guest. So stay tuned to see who joins us next time. Well, you have a great weekend, Jamie, and I'll get to see you in 2 weeks in Indianapolis, but otherwise have safe travels back to Europe.
All right. Thanks. And happy weekend, everybody.
Bye, everyone.